Good morning. This is Donna Kinzer. Welcome to the Payment Workgroup meeting, and I wanted to start by having folks from the HSCRC go around the room and say who's with us today, and then folks on the phone can follow up with that. So, Ellen?
Jerry Smith.
Donna Kinzer.
Allison Schuster.
David Romans.
Barbara Brocado. And on the phone we have
Michelle Mann.
Hank Brady.
Dan Dorn.
some of the mics are muted, so we may have, but those who have not called in, some of your mics were making noise, so we muted your mic. So can you read the names of folks who are muted? Mike Robbins. And Mike Gren and Mary Jo Braid Forbes are also on the line.
Mike Curran's on the line.
Right. Okay. Well, thank you for, and Mike Robbins is also on the line. And Stu, are you online with us? And Kristen Fulio.
I'm here, thank you.
Mike Robbins, could you do a sound check with your microphone because you were making noise before? Yeah, that's not good. Can you call back in on the phone and get off
I
the...
did. When I need a pin.
Mike, they'll give you a PIN when you dial in to the web. It'll tell you to pound with a number and a pound.
Well, I did that. I'm not getting a PIN.
Panel to get your PIN.
Yes, Mike. On the GoToMeeting control panel, under audio, switch to telephone, and then it should give you the dial-in number, access code, and your PIN. Mary Jo. They're calling in. Okay, we'll monitor.
So we think we have microphones under control here. Thank you for joining us by phone today. We had some agenda changes that shortened up the meeting, and we know that that folks are very, very busy right now. So we thought that we would have the meeting via webinar today, and we have 4 items on the agenda. One is to review the guiding principles relative to the market share adjustments, and these are carried forward from the prior meeting with some changes, so we wanted to go over them and prepare to review those in draft form, and they will stay in draft form until we're finished, but review those in draft form with the Commission at the upcoming meeting based on comments from you all today. To give you an update on our data files, then we wanted to review the GBR infrastructure subgroup work relative to reporting on infrastructure for care delivery changes relative to the model. We wanted to provide an update on the transfer adjustment, and then just really start a conversation and a heads up relative to uncompensated care and where we're headed with that. So that is our agenda. And we sent out an updated work plan, and we have been busy working with the data. I think if you look at the work plan, you will see that the November payment work group meeting has been removed, and we will be focused on working in some of the subgroups to make progress on the data analysis. Are there questions before we dive into the first agenda item here? So we will start into the market share adjustments under the global revenue models document, and we're bringing that up here on the webinar, I think. The market share adjustments. Didn't put the Word document. Okay, so we don't have the Word document on the screen. So we'll. I know that you all have that. You received that in your email. So that is really what we were focused on in terms of looking at the guiding principles that and commentary on that we might that we would take forward to share with the Commission in a draft form. We went over this at the last meeting, I guess, and we made some changes to the document based on comments from the last meeting. And we wanted to give you all a chance to make comments on the updated draft so that we could adjust the document. So I guess maybe we could start with folks who have specific comments on the document. I received written comments from Ray Gray, and I don't know if other folks have specific comments, but I'll start with Ray Gray's comments, and then we can take specific comments and then do a general walkthrough again to see where we are. But the first question that Ray raised is, and actually he's raised the question of whether we meant GBR and not ARR on page 2 of our document, where we referred to ARR. Basically, when we talk about ARR, we're talking about approved regulated revenue, but that could be confusing for a lot of folks who were under the readmission bundling program. So we will get rid of the acronym and change it to approved regulated revenue to avoid confusion in the document. So we'll make that adjustment so that we're not confusing folks with that acronym. And it does say that at the beginning, but it's still stuck in folks' mind. I think that that's what we mean, and unless Ray's on the line and has a different view of that. So that's really what when we talk about changing revenue, the approved regulated revenue is what's going up and down. And approved regulated revenue is a concept that applies to both TPR and to GBR agreements. we'll just make sure that the references are clear when we're talking about revenue, and we won't use acronyms. The second comment that Ray had was regarding the principles, particularly 1 point, he says 1.3. And actually, I think he meant 2.3 based on what he has written here. The relative to encouraging competition, competition based on value, revenue should follow the patient, support strategies pursued by entities such as ACOs, PCMH, and MCOs seeking to direct patients to low-cost, high-quality settings. His question is, should there be a corridor or threshold before any adjustments are made to avoid chasing the last dollar between hospitals? And the second question is, could we be creating a potential incentive to make investments that may be unnecessary in the pursuit of market share dominance? So relative to the first question about the corridor or threshold, on page 4 of the document, we have a section that we have not yet addressed yet, which is, it says, to be reviewed after methodology development for calculating shift. And the second item in that list is to potentially use corridors to avoid shifts for minor variation. So that is something that is yet to be reviewed. I think at this current point, we are looking at market share in the context of service lines. So that already provides some we'll call it protection from ups and downs that are that could be generated, and we may actually think of having different corridors for hospitals in areas where there are less distinct market areas than where there are more distinct. So, for example, in the TPR service areas where there are very distinct service areas and hospitals with dominant market shares, we would expect to see less, I'll call it accidental fluctuations in volumes that would come from having a lot of overlap. So we might actually think there would be smaller corridors in areas with distinct market shares, but we really haven't finished that. We really think we need to look at that after evaluating the data. So that's why it's on the list as a to-do as opposed to a specific principle right now. The second point relative to creating a potential incentive to make investments that may be unnecessary. So our view is that that's what the old system was, one where 85 cents on the dollar was being paid for market shifts effectively under the HSCRC regulatory environment. And by going to global models and a 50% variable cost factor, which is what the Commission approved in the January policies, that's actually walking away from the old model that was focused on the market share dominance theory, if you will. And so part of the reason that we're really focused on this market share adjustment is to make sure that hospitals stay attentive to the patients and that they continue to want to serve patients, and so that we're not focusing on having no money move when patients decide to go to another facility. So I think there's a balance that we have to strike. So I don't think we're creating a new incentive. I think we're dulling that incentive with the new system quite a bit. But I would be certainly interested in hearing what others have to say about that as well. So those are Ray's comments. Are there folks on the phone that want to respond to either of those comments or have comments of their own that they'd like to have heard in the context of the document?
Yes, this is Mike Robbins. Can you hear me okay?
Yes, you're perfect now.
Okay. Really to follow up on your comment, Donna, regarding how we've changed the incentives around, you know, going from 85% to 50%. I'm wondering if we look at the top of page 3, right before the guiding principles, there's a statement regarding hospitals pursuing a strategy of acquiring physician practices for increased referrals or redirection of their services to their facilities unrelated to improved value should not be encouraged. I'm just wondering whether that entire section should be removed, because I think that I would find it hard to believe that that's a major strategy of hospitals now, that movement has gone from 85 to 50%, and I think it would also be hard to tease out when a physician practice is acquired or a physician approaches a hospital to acquire their practice, whether that's related to improved value or not. And so I would just feel more comfortable, particularly if we're talking about promoting a competition based on value, that's starting that section that starts with "on the other hand" to the end of that paragraph. I would prefer that be removed in this document. But I'd be happy to hear others' comments on that. I just think that's, you know, it's a tough comment to prove and to demonstrate. And I think if we're truly talking about improving competition based on value, that's inconsistent with the statement that you've made in that paragraph.
Well, this is Stan. I would be disappointed to see that sentence removed. I mean, it's certainly true that it's not always easy to sort through whether a change like the purchase of a physician practice is going to increase the value. On the other hand, sometimes it may be pretty clear that it's simply intended to reposition a hospital so that it can get more revenue, and that the patients in the service area aren't going to be better off. And I think it's an important statement of objective, that, you know, that the point is to improve value. And if there are commercial practices that are just intended to improve one hospital's commercial positioning vis-a-vis other hospitals, and that don't improve the value received by consumers, that's not the kind of thing that ought to be encouraged. So I think it's an important statement of objective.
Well, but I'm Stan, I'm suggesting, number one, I think you have no objective way of evaluating that, number one, and number two, I would also suggest, what I'm also suggesting is that as a matter of practice, that because you've gone from an 85% to a 50% volume adjustment, that you've significantly taken away any prior incentives that may have existed under the old system to grow volume simply for the sake of growing volume. Now that volume, new volume, essentially It may be no greater, that new revenue associated with that new volume may be not greater, in some cases maybe even less than the cost you have associated with those practices. So I just think we've discouraged that, and I just think that I feel just more comfortable with that not being written. Maybe it just needs to be rewritten in a way that just ties it back to the principles that we have stated further on.
Yeah, this is Stu. I think that can be done with this sentence. I mean, it's kind of a long sentence, and there are several clauses tied together. So I think we can make the principle clear without necessarily getting into the kinds of issues that Mike is raising. I agree with Stan that it's important to have that principle stated. I mean, we're all about, stating overarching principles, and I think that's a big one. And I think it's good to specifically state that that hospitals pursuing strategies that increase volume, unless they're related to improving the value of the services provided, are not going to be encouraged, or are going to be discouraged, actually. I think that's a nice statement to make, but we don't. I mean, I think the sentence can be written so it's more both more straightforward and clearer.
And Mike, I don't think that that everyone actually understands the fact that we have dulled the incentive with the change in the system. So it's not clear to everybody that we have changed. Just based on Ray's question, could we be creating a potential incentive to make investments? Blah blah blah, and we're saying, well, we've actually dulled that incentive with the new system, but but people are still asking that question. So I do think that we need to state, maybe we need to actually state the obvious to us, because it's not obvious to everyone else, that we've actually dulled that incentive by having a 50% variable with the new system. So we need to state that, because it's not just the experts reading this, it's physicians and people who aren't, deeply involved in the mechanics of the system. So we probably need to state the obvious a little better and clean up that intro. Would that be helpful?
I appreciate that, but what I was also suggesting is that if we are making that statement, some readers would interpret that to mean that we then, when we do the market share methodology, have to determine in every one of those market share changes that we see how much of that was related to a physician practice that was not related to improving value in the healthcare delivery system. And I just don't know how you ever do that. And that's why I was suggesting just trying to tie that statement to an eventual methodology calculation, I think is to me is a puzzle. And maybe when we look at the data and what's being collected by the commission, you'll have an answer for that. But right now I'm suggesting I don't know how you even do that, and that's why I think it's could mislead one into thinking we're doing a market share calculation in which we're making those calculations and identifying which physician practices were ones that resulted in an improvement in value in the system versus ones which were just strictly for purchases of volume.
So I think the we haven't gotten to the mechanics of the market share adjustment, but for example, here are two mechanics that would be important. So for example, keeping a 50% variable cost factor in place for market share adjustments is one mechanic that would continue to reinforce that principle, because a 50% variable cost factor doesn't provide funding to acquire physician practices. So that's one mechanic that addresses that principle. Another mechanic that might address that principle, and we've already employed that mechanic, if you will, in the transfer policy, is standardizing the amount that is used for transfer. So I'm not saying that we'll necessarily land there, but it could be that we would standardize the transfer dollar amount so that it transfers at a standard level. I'm not saying we will do that, but it's possible that we could. So we could say, okay, we're transferring, we're doing a market shift for orthopedics, and the case mix, the ECMAD change for the hospital is X, and we're going to transfer the money, if you will, at X times the standard value times 50%, so that it could be transferred at something that's not hospital specific. So that could be a way that you could focus on, one way that you could focus on value. Those are just two examples of things that would potentially tie into the principle of not, and also would help us with the objective of having things that balance on both sides, because if we transfer volumes to a hospital that's higher cost and give them a market share adjustment that's higher than the one that's losing the volume, then we're not balanced. So I see that it is possible in the mechanics to address those without examining each physician acquisition. In fact, we wouldn't want to examine the physician acquisition. I think we're actually saying we're not terribly interested in by this, we're saying we're not extremely interested in hearing about your physician acquisitions and that you're losing money on them, as the agency's not very interested in hearing about acquisitions that just move money and that you're losing money and that you somehow want to have your rates set to recover that money when you go out and acquire physician practices. So I think that's really kind of where I would see it coming into a calculation, Mike. Does that make any sense?
I think that is separate from what I expected us to be doing in a market share calculation, but at this point I don't want to take up all of the time on this one. I'd like to see if other folks have comments on this or other issues.
This is Barbara. I think this is an important discussion, and I understand, Mike, what you're saying, and I also heard Stu make an overture to offer to try and work with this language, which is something I think we should think about, because I think, for instance, even if we go back in that paragraph at the bottom of page 2, we get into what a number of us brought up at the last meeting about the subjective nature of high and low quality, and even, I guess it's less an issue in value, but I would kind of go back and Mike, draw your attention where they're in the middle of that paragraph where they want to move members from low value to high value hospitals. I mean, I want to get that low value out of there. You want to move patients to high value hospitals. And then in the same vein, if we can stay on the positive reinforcement mode, we want to assure that whether the physician groups are more efficient and effective as independent contract groups or employees or of the hospital, or whether they move to a larger physician group, that is not in any way colored by a hospital's bottom line. It's colored only by the best, most efficient care, meeting the objectives of this state and the triple aim. So, I don't know, Stu, if you've offered, but I think maybe the language can be tweaked in a way that is just, easier for everyone. I don't have it at the tip of my tongue, but
well,
I think,
I was offering to, to take a look and maybe send in. I have a couple other minor things that really aren't substantive, but just, clarifying words that I'd be glad to, send in. But I'd be glad to kind of take a stab at rewriting that.
That would be terrific.
Sentence, and then and try to preserve the ideas that Donna was talking about and take into consideration what Mike was saying.
So
And
this
this
is
is
Hank Brady,
Michelle.
and not to belabor this, if I could add just a comment. I think I agree with Mike and his concerns, and of course, and I think Donna may be trying to find a solution. But when I read it, my concern is it sounds too black and white. And that is, I would hate to see a situation where acquiring a physician practice is then deemed not a good thing. It's and we'll try to defend it by suggesting it created value. I think we get into a quagmire about that. For example, we have a lot of hospitals on the Eastern Shore, and the community calls for the hospital to bring in certain specialists to avoid the community from having to drive across Chesapeake Bay and up into Baltimore. And they may need to acquire a physician and a practice to come down onto the shore, and that will in fact redirect. Somebody may say, well, that's not value, that's just convenience, and that's not the definition of value. I would want to make this, I would not turn this into a black and white discussion that sends a signal to the industry that we already know there's already a lot of discouragement about just acquiring physician practices to redirect patients. We know that, and Don is making that point repeatedly. I think we got to be careful of a policy that demonizes the thought that anybody who wants to create a new service in their community that's a bad thing, and then we get into a fight about what value is. So I just would be careful of having this turn into a message that would just incite some concerns that we shouldn't have. But Donna's point is a critical one, and that is the policy has already been established to discourage acquiring physicians for the purpose of money. The message now is, if you do it, you're doing it for your mission and not for the money. And I think that statement is already out there. So I'm a little concerned about this whole topic being misread and blown out of proportion. So I like to see this thing watered down a bit and emphasize what Donna has said. This is my thoughts.
If I can chime in and follow up with what Hank said, it strikes me that this is applicable potentially. I mean, I agree with everything that Hank said. I think he brought up the Eastern Shore. I'll bring up Frederick. Over hospitals that are 2 miles apart, 5 miles apart. It seems to me that there's something good about if you have a low market share in a particular service line and you're able to recruit some physicians, perhaps employ them to your locale to be able to provide that service in your community at a lower cost, that should be encouraged, and you shouldn't have to go through some, I'm not sure what kind of screening we would go through, how you'd even say, gee, did you hire some surgeons or some subspecialists to be able to provide that service? And you say yes, and then what's the next screen going to be? Well, is that supportive of the triple aim? And it just feels like we're on a slippery slope there. So I think we do the right thing by having our service lines in the right side of location at the right cost, and it almost sounds contrary here to that ideal, if you will. So I'm concerned about this language.
Hi, this is Stu.
And I think these points are well taken.
that sometimes acquiring physician practices can advance triple aim rather than be inconsistent with it. I think that point is absolutely right. But I think that doesn't mean that this language should be taken out. I don't see this language as saying that the Commission intends to create some kind of a tribunal that will evaluate each purchase of a physician practice to see whether or not it advances the triple aim. Rather, I see this as stating an objective that in crafting policies around market share adjustments, the goal should be to create incentives that align hospital behavior with things that advance the triple aim. And I think that's something that we all, or that many people, something that makes a lot of sense.
Well, I think this is Stu. I think the previous two comments actually reinforce the idea that the triple aim is important, because both of the examples that you guys raised are examples that I think pretty clearly could be argued, at least, are to increase value, right? So I think what we need to do is rephrase this thing in a more positive light, and to say we encourage changes that increase value, but these aren't intended to encourage changes that don't increase value, and that increasing value is going to be part of the conversation in evaluating these policies. I think that's a reasonable statement to make, and it can be made positively without saying, without appearing to say that any acquisition of physician practices is bad, but say acquisition of physician practices has to be aimed at improving value.
It might also be helpful to have a statement in there indicating that that these principles are not intended to say there's going to be a case-by-case evaluation of each of these changes, that the point is to establish that these are criteria that the market share adjustment is intended to meet. Because a lot of the reaction that I'm hearing from the hospital folks is against the notion that that these what I think of are the principles that the market share adjustment is going to try to accomplish. It's being viewed as sort of setting up a case-by-case examination of each acquisition of a hospital practice, of a physician practice, and I'm not sure that that's what this document is intended to do.
And just to add to that,
we can definitely reword that and make it clear, because Michelle's statement, I think basically we're actually saying that if you don't provide services to your community, and you stop providing services and you don't provide services, we're going to take money away from you and give it to the people who are providing them. So we actually are trying to reinforce the continuation of services in the community. So there is a more positive way, Michelle, and Hank, to say that, because we're actually trying to promote that through this policy, that we do want hospitals focused on making sure that they're serving the community needs and having the physicians in the community that need to be in the community, while we're not, but we are not focused on redirection that don't improve value. So there's a way to do that, and we'll ask Stu to jump in and help us with that.
Okay, and just to add to that, because I appreciate that, my sense is if we didn't make it clear, let's just take, you have a service line that you're at a 60% level, let's say, and you know that that because you haven't had the ability to recruit physicians, or now you do, you feel like you're stuck, not being able to bring patients that are going out of your community back into your community, and that just seems like counterintuitive. And when I read this the way it reads now, it feels like it's promoting that inability for a hospital to manage their service line for their community without having a penalty, a potential penalty imposed on them.
Yeah, well, that's not the intent.
Yeah, I know it doesn't. That's why I just kind of agree with the comments that I think that everybody's made about trying to be clear on the intent, so it doesn't have that sort of inverse incentive here.
So we should go on and get more comments. Do we have Mike, or do we have other comments on the document?
I actually, this is Mike. I just, under the principles, just had one question, and that's 3.3. And it may be helpful if at some point we go through the chart that you have later on the market shift calculation. But I just had a question about how would a hospital that, and let's assume for the moment that the higher volume that it has in 3.3 is what we'll call good volume, for lack of a better term, and all other hospitals in their market also have no reduction in their volume in that particular product line. How would that hospital get that additional, the costs associated with that additional volume recognized in their global budget? Is it through, you're suggesting it wouldn't be through the market share shift, but would there be, what I'm questioning is whether they still have some other opportunity to get those costs associated with that volume addressed. And maybe I can do this. Maybe I can do this another way by giving an example, and this has to do with just how granular we might get with this calculation. If I have an orthopedic, Hospital A has an orthopedics service line, and we look at orthopedics at all the other hospitals. If I decide that I'm going to bring in a specialist who handles carpal tunnel and raises the volume of orthopedics that my community needs for that particular condition to be treated more appropriately, or providing better access to that service in my community, so I could see a situation where for that particular case within the orthopedic service line, my hospital volume goes up, but all the other hospitals in my market see no decline in their volume of orthopedics because of the types of cases they do in orthopedics. So how would we address that? I'm just trying to understand how 3.3 would work. If it's not done in a market share calculation, where would we recognize those circumstances, that volume, if at all?
Well, we have a population adjustment. So there's a population adjustment that provides a for volume in a to be honest with you, if you're serving a procedure that's already being served somewhere else, there should be some corresponding volume somewhere else. In the global budget, the concept is that you're trying to reduce potentially avoidable volumes so that you will have an opportunity to provide some new services. We're trying to have the concept is you have a population-based budget that's driven off of population changes, so you get some increase for population changes. And then inside that budget, you are going to focus on how you should be delivering care to the community that you serve. And if you are able to reduce utilization that doesn't need to be in the hospital, that will create financial capacity to have a new service along with the population adjustment. That's the model that we're working with.
Doesn't this this is Jim McGee. I'm sorry for joining a little late. doesn't this kind of raise the whole issue of, number one, sort of population-based metrics and also appropriateness? I mean, I think to some extent, you know, Mike's raising a valid issue, but it also kind of raises the issue of there may be no changes in volume, but there may be changes in the level of appropriateness.
Or perhaps this is Michelle, and maybe I can add a little flavor to what Mike's example, because the thought is, what about if there is an innovation in medicine that comes along and creates that change of service? And I think of some examples that are just related to new things that come out, whether it's a different kind of a joint or something that might move some of those things. And so that may be a reason that a hospital has a higher volume, just because they're doing something different and more of an advanced kind of a thing, and that it just hadn't been done before. So I think that that's one point with that. But the other example that I had, just to switch gears here for a minute on 3.3, is where in, and maybe it's somewhere and I'm just missing it, is sort of the level setting of the PAU reduction before market share. And I can see an example of a hospital whose volume looks like it's dropped. And again, I guess it's the definition of volume, because I noticed we talked volume all through this without, are we just talking inpatient or outpatient or a combination of inpatient, outpatient? But if you did a better job, it seems to me, of getting rid of potentially avoidable utilizations, your volumes could drop relative to your market. And your market might not, it seems possible that your market could have no change at all. So how do we level set for hospitals getting rid of volume? Maybe it's into home care or other outpatient services, SNF partnerships or whatever, but that's not, but in all these examples we have either a volume increase and a service area increase. We never have a what if there's no change kind of, you know, where an individual hospital may have a drop in volume, but the whole service area didn't change in volumes, because, and again, I'm trying to tease out how that's going to get measured. And I think there's two things. One, how we are addressing the individual hospital's progress against potentially avoidable utilization, and then how market share and this population adjustment are intertwined, because I think we're trying to separate them out, but with baby boomers coming in, that's going to do something. We have a population that's going on one set of background data, and then our market share is going to be what we actually have. And that may, I guess what we've been talking about is, you may have a drop at a particular hospital, but not necessarily have a drop in the overall pool that's being calculated for market share. So has thought been given to what to do about level setting PAUs before market share, and how we actually would tease out the change of services provided vis-a-vis the population adjustment?
So relative to you had 3 comments, Michelle, and so some of these, we're getting into mechanics, and right now some of them are mechanical questions, and right now we're focused on principles with this document and not mechanics, and I realize that the two are related. But in our last session, and maybe we need to write something particular in here, but we're not proposing to address innovation in a market share adjustment. So innovation will have to be addressed in a different way, but not through a market share adjustment. So it would have to be done in a different policy manner. So if we wanted to pay for innovation that wasn't covered, if you will, by a reduction in PAUs, or covered in the population adjustment, then we would have to take it out of the statewide budget and award it. So it would have to, just like we opened the new Germantown Hospital and we took money off the top to pay for it, if we wanted to take money off the top for innovation because we didn't think it was distributed in a specific way, or that it was distributed in a specific way, we would have to take it off the top. The other aspect of that is, and so we're not going to address innovation in a market share adjustment. It's just not going to happen. Other aspect of that is, there are some suggestions, and we just received a white paper that say, well, at some point we should be moving more toward an attribution approach where you calculate a PMPM and you allocate that PMPM back out to hospitals for an area. And they have to provide all of the services in that area based on that attribution model. So, in that kind of, as we start to address issues of new technology and who gets to pay for them, then we'll have to start thinking about things like attribution. So that's what we said before, but maybe we need to actually say that we're not intending to address new services in the context of this document. The second question related to PAU 3.8 indicates the intent to look at PAU separately and to indicate that there are a limited set of circumstances where we might want to recognize a shift in PAU. Maybe we should be more specific if we haven't already been elsewhere, that we're not wanting to reward one hospital for another hospital's reduction in PAU.
Mm-hmm. Right, so, because I think that starting point becomes some of the issue with that, but and your PAUs can be hopefully improved other than just the examples that are given.
Right. So I think we did have that addressed, but we could elaborate just a little bit more that that we would avoid awarding a market share adjustment for a reduction in PAU.
Okay,
that would
well,
be our intent.
Okay, I'm not. When you say you would avoid a market share reduction because of PAU?
Yes. So if you lower your PAU, okay, we would avoid reducing your revenues for that.
Mm-hmm. Okay. I think something around that would make that would help with that concept of the PAU reduction before market share that I brought up. So if that's included, that would make sense.
Right, and I think your last point is a mechanical point, but I understand the issue related to aging. Even though we see if you look over the 50 years of history, I guess it's close to 50 years, you keep seeing the days per thousand for Medicare patients drop, 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 drop. It's a steep line down and still going down. But if you take last year's use rates and multiply them by something, you would predict that your next year's volumes would be higher. So, and so we'll think about the mechanics of that, but it isn't panning out. So we have to be careful about building. And one of the things that will make our commissioners think that we've lost our minds is if we tell them that we're going to protect an increase in volumes for aging, but we're not going to reduce the revenue for PAUs when the volume actually drops instead of going up. So, we got to be a little bit cautious on that front when we have things going in both directions. That we've got to reconcile that. But we hear you.
Yeah, and thank you. And just a question here. When you were saying the days per thousand, are we looking? Is that an inpatient number? Because with the observation, I mean, I know in our hospital, I don't know how it is in other places, we're still seeing the same number or actually increasing numbers if you put observation patients that are staying 1 to 2 days plus the inpatient. So the change is almost definitional over a reality. I just wanted to see if that's been considered.
The literature really doesn't support a lot of volume growth around aging of the population. If you actually read, there's like a decade of literature on it. What it does say is new technology is really driving volume increase and not necessarily aging of the population. But anyway, we will readdress that issue, I'm sure, in the mechanics.
All right, thank you.
This is Barbara again, and anyway, I'm amazed at how much you guys get your arms around. It's really, for somebody that's new to this, it's really amazing. But I think, Don, I just want to put a second to your suggestion about mentioning in relation to Mike's concerns about 3.3 that it's not covered in this document. I mean, there's so many what ifs, and I think, Mike was right to raise that question about, innovation. So it just seems to me, as you said, this is a document about principles, and when we're worried about potentially where it could lead, to say up front, this doesn't cover that is a really smart move.
I think what I just heard is that we should insert a bullet in there that says something to the effect that innovation is be treated separately. Did I understand that correctly?
Yes.
Okay.
Yeah, I would go a little bit farther than that. I would put in a sentence or two saying that market share adjustments should not be viewed as the only way that hospitals can receive an increase to their budget. That there are other that there are separate policies that would address innovation in healthcare delivery and also demographic changes in the local area. Because I'm just when I think about it from the sort of the communications perspective that we were talking about earlier, people will read this document and say, well, the market. What if X happens? What if there's more people? What if there's more overall demand and so forth? And to sort of forestall those questions, or at least provide something that you can point to, would be nice to put that in sort of in as part of the context for this. That this is not the end-all and be-all of budgetary changes for hospitals. Rather, this is just one
piece.
Yes, exactly.
So it's not the only way. There's the population adjustment. There's reinvesting funds from efficiency gains, et cetera.
Yeah, and that there's also a question about how, as a state, deal with innovation and changes to medical practice that occur in the hospital, and that's not an issue that the market share adjustment is intended to deal with.
Well, to some extent, that's addressed in the very first sentence.
All
say first in? In the introduction, is that what
Yeah.
you're suggesting?
Yes.
To
Oh,
some
okay.
extent,
Yeah. So you have that broad statement there, yeah.
But you know, in this call and in other discussions of this group, we've had some very sophisticated people raise questions about, well, what do we do in case of innovation? What do we do in case of changes in demographics? So I think a little bit more spelling out of the role of the market share adjustment vis-a-vis other possible factors that could change a hospital budget amount, and that would maybe be helpful.
Yeah, so
Yeah,
I think what you're suggesting is that we just state that so that it'll be clear to folks, because not everybody would necessarily understand what those tools are. So let's tell people what the tools are that provide funding for services, the population adjustment, the improvement in efficiency, the reducement of avoidable utilization provides a funding source for service delivery.
Yeah.
State that and make it clear that this isn't the only way that there's funding provided for service delivery.
Right, and that there's a further issue that needs to be grappled with, namely how we deal with technological change and other innovations in healthcare delivery that might have an impact on hospital budgets, and that is not what the market share adjustment is intended to address.
This is Ann Mack. I would agree with that absolutely 100%, and listing out specific things that may be taken into account with the caveat that we're not specifying sort of a ranked order of what would be considered before you would go to market share adjustment. In other words, you're not mandating that all these other things be considered first before a market share adjustment.
Okay.
Well, it seems to me that, as again, as we look at the introductory remark, just to have that spelled out a little more specifically would be helpful. But that does provide the I don't know, safe harbor that we're looking at. That the market share adjustment is not everything. That seems to be, at least what I'm taking from the discussion, and would be very helpful.
Thank you, Barbara. And that's and I'll ditto that from talking with physician groups about it when they have questions. So that is actually the part of the discussion. Other comments or questions on the document?
I had two. I had one comment and then a question. The comment concerns the statement on page 2 about hospitals should receive an increase in its ARR when organizations like health maintenance organizations, etc., channel members from low-value to high-value hospitals. I guess, and the concern that I have is that it may be that sometimes that an insurer could channel its members from one hospital to another for reasons that don't necessarily serve consumer interests or advance the triple aim, but do serve the commercial interests of the insurer. And now that, the statement in the document as is fine, because it says that it's talking about circumstances in which such change increases patient value, or increases healthcare value. But I guess as a practical matter, I think it would be important for there to be transparency about what the contractual arrangements are between hospitals and insurers, or hospitals and patient-centered medical homes, when there is a shift that takes place at the behest of the insurer or the medical group, to make sure that you all know what the financial drivers are of that shift.
Well, Stu, this is Barbara again. I think that I brought out, and I'd kind of suggest taking out the...
That was Stan. I think that was Stan, right?
Yes, it was. Yes, it was.
It was Stan, not Stu.
Oh, Stan.
Okay.
Stan. To take out, if we took out the from the low value, but went on to say that, you know, that these entities, you know, should channel their members to high-value hospitals when it improves efficiency, cost-effectiveness, and quality. Is that?
We're not actually suggesting that they should channel their patients.
Okay.
We're just saying that when they do. So we're not suggesting they channel patients, but we're saying when they channel patients, that that we want to make sure that there's a mechanism to move money.
Right.
And so there we could have XYZ HMO says, I want to move my patients from X hospital to Y hospital, and they could come in advance, and we could actually look at their patients, and if they have the ability to channel, we could move money. So that's really just to make sure that we don't have a principle in place that would stop an HMO that actually has the ability to channel patients from doing that in the proper context.
I guess I'm with you, but I guess to Stan's point also, that if a hospital is going to get an increase when one of these entities channels their members, what we want to make sure is it's for, you know, quality. It's for the triple aim, and does, you know, again, that language from low value to high value, color it in just with too much of a financial emphasis. I think, I don't want to put words in Stan's mouth, but that was my concern as well, that you want to make sure, with experience that some of us have had with MCOs and, you know, their financial interests, we want to make sure that that's not the driving factor, that it is that overall goal of that the state of Maryland has and the triple aim has.
Okay. Are there other comments on that? Let's see. I have notes here. One of the notes asks about out-of-state volume, and that is clearly a mechanical issue. So, Camille, we have some. Let me make sure before I go into the questions of folks who are not on the payment group that we've tackled the payment group first. So, are there more comments from the payment work group members?
I had a question about the tables. I didn't understand some of the comments. So, for example, in the first table on page 4, the third unshaded row, the final comment in the right column, hospital AE increase is less than the absolute value of decrease at other hospital. Shift equals ABC increase. I don't understand what that means.
Okay, so suppose hospital A increases 100 cases. It's in its market area, there is a decrease of 50 cases. So the shift is 50 cases, not 100 cases, because the decrease is less than the increase.
Sure.
Or, on the other hand, if hospital A has an increase of 50, but there's a decrease of 100 in the market, then the shift is limited to 50. So those were the two examples that were supposed to be teed up by that statement.
So I see. So in other words, if there's a difference between the increase and the decrease, then the shift is the lesser of the two.
Right.
Okay. That's not clear from the way it's written. At least it wasn't to me.
Yeah, I think we ended up having a PowerPoint because it wasn't clear.
Okay.
So we do have a little PowerPoint to show that, but I guess what you're pointing out is that we still need to continue to work on the wording of this table so that it makes sense to somebody who's looking at it.
Yeah, I mean, I think a way to put it would be to say if the increase is different in size than the decrease, then the shift is the lesser of the two.
Okay.
That way you
Don, yeah. Donna, this is Mike. Right above that table, when you're talking about the actual calculation, you have the first one where both volume and market share must have increased. Then in the second example, you say both expected volume and market share must have decreased to receive a negative market adjustment. Is there anything to be read by use of the word expected there as opposed to simply saying both volume and market share at a hospital must have decreased? What is meant by
I'm not 100% sure, so I'm going to ask Shuli about that word.
Okay.
We have gone back and forth with some expected versus actual calculations, going back to Michelle's interesting point of how to intertwine population changes with market share changes. So we have had some interesting thoughts about that. So it may have been something that was carried over, but I'll double check with her.
Yeah, I was just thinking why it wouldn't be in both directions if you're
Right.
going to use expected.
Yes.
But this is Jim McGee. Oh, can you hear me?
Yes.
Yes.
Oh, I thought I actually had my phone on mute, and I'm not understanding why it doesn't go on mute. But anyway, sorry about that. I think touching on the issue I raised before about population-based metrics, if you have a market area that clearly has some service line that is being delivered disproportionately high relative to the rest of the state or the country using some kind of population-based metrics. And is that what you're referring to when you say expected volume? You know, is somehow that taken into account when you're making these adjustments? If the particular market area is coming in line, I mean,
No.
I don't know if I'm making any sense.
No. What you're saying is making sense. So you're saying, if we used a model that predicted the volumes based on a risk-adjusted model of effective use rate for a particular service, is that contemplated in the market share adjustment? And so I'm saying no, it is not. We don't think we're at this. We're not an arbiter of that, and I would say that we've had about maybe 20, 25 years of Medicare Advantage, and they haven't figured out how to do that. So it's not something that we're trying to take on in this particular policy.
Okay. Thanks.
To the extent that it's in here, it's relative to the PAU. So that's the extent to which we've taken it on in this policy at all, is in the PAUs.
Yeah, the PAUs are a specifically defined set of DRGs or admission causes. So
right, but we have not said, oh,
right.
geez, the use rate for orthopedic surgery is higher in this area of the state than that area of the state, and therefore we're going to predict lower utilization. We have not taken that issue on.
Or contemplated measures to reduce that.
Correct. Not in this policy, not in the market share policy. Yes, we have not taken that on in this policy. And the global budgets takes that on at some level, but we haven't taken it on as a specific policy at all, other than the PAUs. Any more comments or questions? And before we turn to the questions and emails, Ray, I know you're on the phone now, and I already raised your questions, and folks commented on them before you got on the phone.
Donna, can you hear me?
Yes.
Okay, this is Ray. I was listening the entire time. I just had a momentary problem with getting the audio control going, but thank you very much. The only question, one comment about all of that information, and then one question. One is relative to the physician practice issue that you spent a good deal of time on. I'd only like to comment that primary care physician practices are very important to managing population health, and the institution, as you and I have talked numerous times about aggressive outpatient case management programs within the offices, will enable the triple aim. Just a comment. So I'm not sure that owning or losing primary care physician practices is always a bad thing when you take into account the benefits that may be derived from this practice. The only question I had was right back to the point that was just being discussed. What do you mean by expected volume? Is that a calculation?
So we just said that we would take that word out unless Julie had a specific reason for leaving it there. Right now, I don't know why we had it there, and Julie's not with us today. Other questions or comments from the work group? So Camille has 3 questions or comments, and the first one is, if transferring to AMC grows, couldn't it be because of new innovations that help patients that AMCs have that local hospitals don't? That innovation could be funded through transfer growth, and the answer is yes. That's an example of how an innovation would be addressed outside of the market share policy. So that would be one. The other one that we've addressed already is categorical patients, which are transplants and highly sophisticated cancer care patients where there is innovation. And we have separate budgets for those, as you all know from the policy drafts and from the contracts. And those are also funded in a separate way, and so those also do recognize innovation. And we are having innovation in transplant surgery right now, and we are paying for that out of the statewide budget. So maybe we could actually mention those two examples in the document in the footnotes somewhere as examples of innovation policies that have already been put in place for specific types of innovation. So mean of the categoricals and of the transfers. So those were Camille's questions on that. Does anybody have comments on that? Okay. The second one from Camille is if cases come in from out of state, but no other Maryland hospital sees volume decreases, how would we address this? So there are, I think there are a number of institutions, particularly those on the D.C. border, who have an interest in this particular issue. And we will work with hospitals to identify cross-border changes in volumes that occur. And we do have the possible potential to address them within the context of a market share adjustment. Our contract with CMS allows us to approach them if we have market share changes, but we still have to evaluate them based on value, just like the other items. But it's harder because we don't have all the data. We're getting the data. We're getting data from Medicare for the border states. We don't have it. We don't have it yet. But we're getting it, and we'll have more tools to evaluate that with the Medicare data and the all-payer claims database data. We'll have better opportunities to evaluate border crossings, which we're very interested in both directions, either patients shifted out or patients shifted in. And we'll work on that with hospitals that have significant changes. But again, in the context of value, relative to those changes. I think I addressed Camille's comments. We have Kathy Talbot, Camille, and Commissioner Jenks on the line. Does anybody else have any comments or questions relative to this document?
This is Stan Dorn from the Urban Institute. I think it's a good document. I think it's definitely on the right track.
Well, we have some rewording and wordsmithing to do, but that's always good to try to make things clearer, and we'll make those changes. The next, I just wanted to give you a brief update on where we are with the data files. And in your set of documents, there is a table that is fiscal year 13 versus fiscal year 14 product line trends, all patients. We have been working diligently to get all of the data grouped into product lines. The outpatient product line still needs some work. Right now they were grouped based on the high CPT code, and we really want to do some work with hierarchies. We're in the process of regrouping the outpatient with hierarchies, but it is a document that is interesting in terms of being able to look, at least at first blush, at what's in the different product lines. These are state residents in the data in terms of what's in the reported in the hospitals and the product lines in what's been provided to you. And we have a comparison of fiscal 13 versus fiscal 14. I know that we're in the process of making these data files available under a data use agreement to folks who want to look at them and help us, kick the tires with some of the service lines, recognizing that we're continuing to work on, particularly on the outpatient side. And I think Andy's sitting here, we're fairly close to, but we were getting ready to release the data pretty quickly here. Let's move on to the infrastructure, and we're going to let Allison take over.
Good morning. I will make this brief in the interest of time. I'm going to review the subgroup's work on developing a reporting structure and template for investments that hospitals are making in reducing potentially avoidable utilization and improving population health. So the purpose of this reporting will be to inform the HSCRC and other stakeholders, including CMS, on what are the amounts and types of investments that acute care hospitals are making over in time to improve population health and reduce potentially avoidable utilization, and how effective these investments are. I'm going to actually skip ahead to the principles because they cover most of what I had in the purpose. And I wanted to just note here that we are saying that the fiscal year 14 and the fiscal year 15 reports, the subgroup felt that hospitals hadn't had enough input and time to develop the fiscal year 14 report. So what we've done is said that the final fiscal year 14 and 15 reports will be submitted together and be due within 90 days after the end of fiscal year 15. Again, this is so hospitals have enough time to submit these reports. However, we did put in a stipulation that interim reports may be submitted to the HSCRC for feedback and will be required for any hospitals that are seeking an increase in their global budgets or relief from rate corridors. The second principle is that the qualifying GBR investments that will be reported by hospitals will be for new programs or technologies or major expansions in existing programs that are directly related, again, to the GBR incentives to achieve the triple aim. These investments are not limited. We don't want hospitals just reporting on what they spent the additional money that's in the GBR budgets. We want them to report it on all major population health investments. And we're not trying to assess whether hospitals spent the full amount of money, nor, again, are we wanting them, we want them to report the total amount, not just what they spent of that money. Again, the investments that they report, the third principle says they should be broad in scope and have the potential to impact population health within the communities that each hospital serves. For the GBR investments included in the report should be data-driven and should be able to be evaluated using measurable outcomes. We have, on the next few slides, expenses that we are saying that we are including under this, and then some excluded expenses. However, as one of the principles, we're saying that the HSCRC will review requests to include expenses that aren't currently included on this list. And finally, again, going back to the purpose, the reporting of GBR investments is important for educating CMS and other stakeholders on the new waiver activities and results. So skipping to the next slide, the types of expenses to include in the report. And you do have the Word document that goes into a little more detail on this, but we have 3 categories of expenses. The first are patient-centered interventions, things like care management, care coordination, things like medication and care compliance initiatives, and it could include things such as needing to pay for transportation or prescription medications for patients who can't afford them. The second category are provider care team investments, and the examples I give here are coaching or other support to encourage compliance with evidence-based medicine, or infrastructure to set up a pay-for-performance or shared savings program would come under this category. And then the final category would be any sort of health information technology that would support the patient-centered or provider care investments. Any sort of predictive models for care management, and other sort of data items. I also listed here the excluded expenses. Again, we're looking for things that if you're just implementing electronic health record, unless you're specifically implementing a portion to deal with care coordination, those things would be excluded. Things like billable services, any sort of marketing expenses, and actually any sort of financial reward for providers for pay-for-performance incentives. And this is just the report. These are the fields that we'd be asking hospitals to submit, and currently we have an Excel sheet set up, although we'll be looking potentially for other mechanisms for people to submit this. 2 of the subgroup members were kind enough to work through a couple of examples, and those are included in the appendix of the report. This is one here, and again, it just shows you'd be reporting what investment category that your investment falls into. Again, we're looking for things. We're not looking for things to be reported in sort of a line item way, but more in sort of a program way by these investment categories. So, for instance, if you had a care management program that had a health information technology component, we would kind of want you to report the patient-centered portion and then the health information technology portion under a separate investment category, just to give us an idea of the two, that level of granularity, but without needing to report investments sort of as each line item. We also asked for a brief description. We're looking for what is the target patient population, so even if it's an HIT or a provider intervention, what is the patient population that would be impacted, total expenses, and whether or not any are covered by grants, when the planning started and when the actual intervention or investment went live, what types of staff are involved, and what are the total annual FTEs, what type of external partners the hospitals are working with or links with existing statewide or regional infrastructure. And then the last these next two are related to outcomes. So here we would want you to either give outcomes or proposed outcome measures if the investment is too new to actually have outcomes data, and then talk about the effectiveness of the investment in achieving its goals, including any discussion of barriers or lessons learned. So I will stop there. Again, I want to thank the subgroup members for their input, and we will be circulating, this is still in draft form, and we are looking for feedback either now or later. Are there any questions from the subgroup members? From the work group members?
Can I, under excluded expenses here, you exclude expenses for acquiring physicians that do not clearly improve access to primary care services. I'm wondering if we might take out to primary care services. Maybe I'm wrong, and I have to say I just came back from visiting one of my clients that's based in Florida. They're a national group. They're Mednax. They're the biggest neonatology provider in the country. I think 1 in 4 of their babies are, anyway, they take care of one out of every 4 neonate babies are cared for by them. And what I learned there, I just, again, the neonatologists with high-risk pregnancies and how they work with the primary care doc and, you know, the OB even prior to these deliveries. So I just, you know, when you say improve access, I don't know why we need to limit it to primary care, because the quality, the qualification is here. You know, you want expenses for acquiring physicians that, again, that do result in that coordinated care effort. And if that involves acquiring a practice that's not primary care, why that should be outside, why that should be excluded. So.
Well, we might actually take all physicians out because we're just really not interested in general in having physician practice acquisition be part of the interventions that we're really looking at. So I guess we were trying to be sensitive in particularly in some of the rural areas where we have severe primary care shortages, that we might at least consider looking at some recruitment expenses or something of that nature that could be reported as how a hospital had decided to spend some of its savings, if you will, as an intervention. And honestly, we're not really interested in the broad of calling the physician practice acquisition a broad intervention to improve care delivery, because that just opens up the whole acquisition strategy. I'm sure that nobody acquires a physician to not improve care delivery in some way. So I think it was just trying to be sensitive, particularly to the rural hospitals, and maybe we need to just think.
Right, and I just want to draw the attention, in the Word document there is a bullet under provider that says, and I just want to make sure we're being consistent, that seed funding to recruit new primary care providers and or subsidies to primary care providers to increase and ensure continued access for care for certain health conditions or populations would be included.
So I guess the PowerPoint document is a higher level, and actually if you get into the Word document, it's more specific and limited. It's on page 3 of the Word document. It says,
so the Word, you're in the PowerPoint.
So it's even more limiting when you get to the Word document. It says seed funding to recruit new primary care providers and or subsidies to primary care providers to increase.
Oh, here we go. Okay, I hadn't looked at this yet.
So it's very, very specific.
Right.
And it was intentionally very specific.
Right. I mean, we were taking the subgroup's feedback that there is some, acquisition of providers to increase primary care access that should be counted. However, we're sensitive to this issue of just using it.
I have a question. This is Jim McGee. And from where I sit as an employer-sponsored plan, we have often been in the position of hiring third parties to do care coordination, sometimes independent from to date, independent from the insurance companies. Now the insurance companies are all getting in this business. My question is, how do these sort of third-party efforts tie in with what the hospitals are doing, and to what extent do they impose or share costs with hospitals when they do their care coordination efforts? And how I'm curious how this all factors in. I mean, the most notable example, for example, is Care First has a very broad patient-centered medical home initiative, and they're taking on a lot of this care coordination role. How does that tie in with what hospitals are doing? Is it duplicative? Is it interactive? Does it impose additional cost or less cost for the hospitals?
We're starting
I think it's great that the hospitals are. This is where the care coordination belongs, at the hospital level, and not at the third-party level. But I'm just curious how this all gets factored in.
There is a new work group on care coordination that is starting. Its first meeting will be November 17th.
Well, can I get on it?
Me too.
to participate as commenters as always, but you stepped into something that will be a very big question and ongoing need for coordination that's already been discussed widely during some of the SIM proposal, the state innovation model, but will be discussed again in this effort. So we are taking that on as a separate work group activity.
But again, I think coming back to this reporting, it'll be helpful for us to have an understanding of what the hospitals are spending to inform that work group in terms of care coordination.
And I guess I go back to the important things because, again, and the investment of time and resources, because, again, with clients outside of primary care, even, anesthesia, looking at an initiative they have that's, a surgical home.
We're not going to add any of that in here. If anything, we'll take primary care out. If it starts creating angst for others, we'll just take primary care out and have nothing. But we're not going to add physician acquisition in here, honestly.
And Donna, this is Ann Meck. I support you 100% in that, to stay away from physician acquisition because of the tendency then to try to induce demand. To the extent that primary care fosters the population health out in the community to keep people out of the hospital, that would be the only reason I would see to leave it in there. Otherwise, I would support you if you wanted to take it out entirely.
What do others think? Should we take primary care out entirely, or we have it now as a separate? It's a separate item to report, so we can consider it separately when we look at it. I mean, it's not going to be grouped with something else, so it will always have the ability to really separate it out and look at it as a separate item. What do others think? Any other opinions?
Again, I have no problem with it staying in. Maybe it is a good thing in terms of access. And again, I'm not looking, when I talk, and maybe I'm mixing oranges and apples here again, but when I brought up the broader investment that is being made by, in the surgical arena and by physician groups, that it's not applicable in an acquisition discussion. But
well, the other initiatives are covered here. So if there is something that's being invested in, all the other initiatives are covered here. So if there's something that's being invested in, we would want to report the investment. We just wouldn't want it to have anything to do with recruitment of physicians.
I guess I think that one of the roles of the primary care physician is care coordination, or should be care coordination. So I see the challenge of separating out that kind of activity from other kinds of physician acquisitions. But I think we need to respect the role of the primary care physician in the care coordination process. I guess that's my gut reaction. This is Jim McGee.
Yeah, this is Stu. I've got a similar. I'm kind of torn because I understand the fact that you don't want to exclusively focus on primary care, but primary care is supposed to be the core of the new health system. So I think maybe saying something like primary care, and then having a label, and other activities intended to coordinate care, or something like, to tie it to the triple aim, but not necessarily say that it just has to be primary care. And there's also the question of defining what primary care is anyway.
Stan, there may be another way to address it, which is to say on the bullet that's in the included expenses category, namely the bullet that begins with seed funding to recruit new primary care providers, you could add a clause that says, and or measures to address gaps in community healthcare infrastructure, and or measures to address other gaps in community healthcare infrastructure. Leaving it open to, if there's a particular area of Baltimore that doesn't have maternity care providers, or a certain kind of or mental health providers, for example, and a hospital was wanted to address that, and that seemed like a measure that would prevent initial hospitalizations. You'd leave the door open to that, and then maybe but not address it in the context of the physician acquisition, the physician practice acquisition, the excluded. So I mean, really, are we thinking that the way that a hospital is going to address infrastructure gaps in the community is by buying physician practices?
We've had a lot of folks tell us that they want to include all their primary care and other acquisitions as their care improvement plan. So we're actually even saying that if you buy a physician practice, a primary care practice in, I'm just going to make this up, but in an area, and you're not actually increasing the capacity of primary care provision, we're not interested in hearing about that, because that's not really increasing the capacity for primary care. So
exactly.
So we don't really want acquisition at all.
Yep.
That's
why I think Stan's wording is actually good, because it addresses the focus on the community's capacity rather than the individual system.
But
so it's
put
a community,
it up in the included expenses category, that don't open the door to more physician practice acquisition. That is, where the bulk is to seed funding to recruit new primary care providers and/or subsidies to primary providers, et cetera, and/or other investments to fill gaps in community healthcare infrastructure.
This is Mike Robbins. The only question I have in terms of the acquisition of physician practices, and I don't know exactly how this would work, but this may be part of a physician alignment strategy. You want to make sure to be successful in managing population health that you have good alignment with physicians and other providers in your community. And so it may be a question of whether you have sufficient numbers of providers or providers who are willing to work with you on managing population health. And I just raised that as an open question. I just think that there are just some questions being raised right now on how the purchase or setup of new physician practices may be part of an alignment strategy for managing population health, as opposed to simply driving volume from one hospital to another.
And this is Barbara.
Go ahead.
Mike. No, I'm kind of seconding what you're saying, because I've got so many questions in my head right now, because I know from the physicians that I work with across the board, whether it be emergency medicine, anesthesia, radiology, the neonatologists, the surgeons, and I know, again, the investment and the thought that's being gone on in anesthesia about pre-op, post-op, following the patient out into the community to control their pain. I mean, what is in the community with the emergency physicians, their initiatives and thoughts about how they can reduce readmissions by having continuity with the patients that they see in the ER back into the community. And so this stuff, in my mind, that just, lights keep blinking in my head. Are we restricting things here? We may not be, but that question lingers for me.
This is Ann Meck. That I think I'm concerned about going down a dangerous slope, because I think there is a dual purpose that I see being identified, trying to make sure that there are adequate resources in the community, but also possibly through acquisition, setting up some alignments, directing care back into the hospital. And I also get concerned when I hear things like emergency physicians and anesthesiologists sort of circling back into the community. may be appropriate, may not be appropriate, but I would also look at, before we go down that slope, what is the role of the care coordination between the primary care physicians and the specialists that are already in the community to be able to manage the patient adequately, before we start doing anything that would encourage more hospital-based physicians or hospital contracted physicians with sort of developing a new market share out in the community.
This is Mary Jo. Can we step back a second? And the purpose of the report is to find out what specific programs people are doing to invest in the communities to reduce hospital costs. And of course they need to align incentives and talk to their doctors and things like that. But that's not a organized program of the type that are envisioned in this document that people would be reporting on. You know, to the extent that you've aligned your contracting with physicians to make sure they're rowing in the same direction as you are, you can describe that in the description part of these a broader initiative. But that in and of itself is not a initiative to report on in this context, and that's my thought.
Well, this is Mike. I'm looking at the instructions on this, and for the background document, and maybe it's what I think may be missing here on the bottom of the second page, where it talks about, as it's talking about principles and then the types of expenses that are included. On the very bottom of that page, it talks about infrastructure to set up pay-for-performance or shared savings models with providers, including legal expenses for vetting pay-for-performance programs, and infrastructure for gain sharing, comma. And I don't know if there's something missing there, and the example I'm thinking of is, were there some other programs we wanted to list there that are these type of physician alignment programs that are included expenses. And so it's not the cost of underwriting the physician practice, but the cost of setting up that infrastructure.
Right, I think that we've tried to identify it there.
Yeah, and again, maybe it's a typo, but
there's nothing missing.
Yeah, there's nothing. It's my weird formatting. I apologize. Okay. Where each of them are. Anyway, just ignore it. There's nothing missing. But if there are suggestions of things that need to be added.
No. Hey, Donna.
Yes, sir.
It's Mike Curran. I would just ask for, again, there's a lot that still needs to be learned as it relates to relationships with our primary care physicians, but there are multiple examples, obviously, by, and people had mentioned this earlier, by having everybody on the same page, sharing information, sharing protocols, making sure that folks are available so that we don't have unnecessary ED visits or admissions to our hospitals, can only be done if you have a very, very strong linkage with a comprehensive primary care strategy. So again, while I hear the comments about we don't want hospitals being out there acquiring physicians, and I agree you shouldn't be doing it for market share growth, it does tie directly into all the investments you're making, whether it's in technologies or information systems, to make sure that we can appropriately treat people in the right setting. And sometimes that means you do have to acquire physicians in a certain area to do so. So I would just ask for a little bit of openness.
Yeah, we weren't saying that you shouldn't acquire them. We were just saying that we didn't want to report them as a care management or population health expense.
I appreciate that, but again, there was other comments about we don't want you guys doing it. I just want everybody to remember there are legitimate reasons for us to be doing it. Whether you include the costs or not,
for me was more the nature of the conversation more than whether you include it or not.
Yeah, I don't know whether we made a definitive policy statement about what we wanted, what we were wanting you to do, or whether it was good or bad. It's just that we weren't wanting to encourage it in the market share policies, that we wouldn't want to encourage increased payments.
Then I appreciate and
occurring as a result of it, but not. I don't think we were trying to make a statement about it in general in these documents. I actually think the rewrite that was suggested was really trying to make that a little bit clearer. But
thank you.
Yeah, right now we're not trying to weigh in on the policy debate that's going on nationally about whether physician acquisition is good or that it saves money. There's 3 articles in, I think it's either in New England Journal of Medicine or JAMA this month. I'm not sure which one it's in. I can't remember. I think it's a New England Journal saying that practice acquisition actually increases the cost per capita, not decreases it. But that's a debate that we're not ready to dive into. So we're not trying to. So if it looks like we're trying to get into that debate, we're not.
Appreciate that comment. Thank you.
All right. So I will take some of the feedback here, and we will try to clarify a little bit of some of these points. But if you have any other additional comments, feel free to get in touch.
Are there other questions or comments on the reporting document? Moving on to just provide a brief update on the transfer adjustment. We believe that we have made sufficient progress in reconciling the transfers to move that policy implementation forward, and we're going to reconvene the subgroup to go through a proposed timeline and approach for implementation. So that will be coming back up at our next meeting, but we are moving the process forward on the timeline. And once we get a review from that group, we'll forward the information back to the payment work group. The last item on today's agenda really is to talk about uncompensated care, and just to indicate that it is an issue that we said that we would address, we would begin to address during the course of the year. We are looking at the payer mix data coming in on the case mix data, and we're seeing some significant declines in charity and self-pay revenues, meaning that, and increases in Medicaid revenues, so that individuals that were previously uncompensated are now being compensated. The dollar flow of those items looks like it's shaping up to be larger than the reduction that we made on July 1 for uncompensated care. But at the same time, we realize that we don't have all the information. We don't have the information on what's happening with uncompensated care for deductibles and co-payments and other trends in uncompensated care. So we are, but we just wanted to let folks know that we're going to start picking up on the issue and looking at the data in the upcoming meetings and begin working on the uncompensated care issue again, since we now have 8 months of data under our belts that we can use to see post ACA what's happening with some of the payer mix. We did say that we could potentially make an adjustment during the year if we saw a significant change. We don't know that we're going down that path. We're not suggesting that we're going down that path, but we are going to start looking at the data to see where it looks like we're headed. Most of the feedback that we've gotten from the hospitals is that things are changing pretty quickly, and they're trying to update their uncompensated care calculations as quickly as possible. They're historically formulaic driven, and when you have such a massive change, the formulas have to be reevaluated, and so folks are still, the hospitals are still trying to grapple with how to get their formulas working well with the new data. So I think that is an update on that issue if anybody has any comments. One other document that we provided to you, I think at the last meeting, we were asked to provide PAUs by service line, and so there is a document in your data that was sent out that shows what the dollar value of PAUs is by service line. And I think we have PQIs and 30-day readmissions reported by service line. I think Shuli wanted to point out that there could be double counting in those dollars. They're not exclusive to each other, so something could show up in the PQI column and also be shown in the 30-day readmission column. We did not attempt in this analysis to deduplicate the numbers. So I think that gets us back to our timeline, and we are going to be focused on getting back together with both the transfer and the market share subgroups to work on calculations. We're getting the data out the door, and the next meeting that we have of this work group is scheduled for December 15th. We're hoping to make a lot of progress in between now and December 15 with the data and the sub-work groups. Are there any questions or comments from the work group? Any questions or comments from others? Well, then I think we're concluded with today's meeting. Thank you.
Thanks a lot, Donna, and thanks, everybody.
Thank you.
Thank you.
Bye-bye.
Thank you.